welcome to the March GIC meeting. I am looking forward to today's agenda. Premiums and discussions around rates are always so very lively. I want to announce the commissioners who are here, welcoming all our YouTube streamers and watchers. So I'm Valerie Sullivan. I'm joined here by Commissioner Adam Chapdelaine, Commissioner Anna Dor Seneko, Co-Chair Bobby Kaplan, filling in or assigned by ANF, Cassandra Roeder, Commissioner Clenard, Commissioner McEnany, Commissioner Gerard, Commissioner Edmonds, Commissioner Gentile, Commissioner Rodriguez, Commissioner Jennings, Commissioner Rebecca Butler in the seat for Division of Insurance, Commissioner Tamara Davis, Commissioner Sullivan, Tim Sullivan, Commissioner Choate. Thank you, commissioners, for your service. And I will now ask my commissioners for the minutes from the February meeting and see if there is any discussion around those minutes. If not, I will take a motion to approve the minutes.
So moved.
Thank you, Jane.
Second.
Do I have a second?
Yes, Commissioner Kleinert seconds that motion.
Okay, so we do have the motion. I am now going to pass it over to our general counsel to take roll call. And starting with me, and each commissioner will say yay, nay, or abstain. Commissioner Sullivan, yay.
Thank you, Madam Chair. Commissioner Kaplan?
Yay.
Designee Roeder?
Yay.
Designee Butler?
Yay.
Commissioner Chapdelaine?
Aye.
Commissioner Choate?
Yay.
Commissioner Clenard?
Aye.
Commissioner Davis?
Yay.
Commissioner Guerin?
Yay.
Commissioner Edmonds?
Yay.
Commissioner Gentile?
Yay.
Commissioner McEnany?
Yay.
Commissioner Jennings?
Yay.
Commissioner Rodriguez?
Yay.
Commissioner Seneko?
Yay.
And Commissioner Sullivan.
Yay.
The motion passes unanimously.
Thank you, Andrew. So at this point, I will turn it over to our Executive Director, Matt Fino.
Thank you, Madam Chair, Madam Vice Chair, members of the Commission, members of the public tuned in, and to my staff who have joined me on the Zoom call. Happy almost spring to everybody. I don't know if anybody had the chance yesterday to get out and about, but it was the last few days have been sort of the hint of early spring. I knock on wood as I say that. It's been quite a year. So anyway, thank you all for joining us. If we can move to the calendar, actually to the next slide, which is the agenda here, and to the next slide, please, to the calendar. So you'll see we only have two primary substantive items to take up today. As Chair Sullivan noted, we take the last step in our multi-step process to prepare for our products and plans and premiums for the upcoming annual enrollment. It involves a number of steps, including the health plan rates, but also a variety of other votes by the Commission to support those rates. We will also, subsequent to that, have a presentation by a guest speaker from CVS Caremark, who will give a really timely presentation about vaccine hesitancy, particularly in the environment of COVID, where getting the vaccines into people's arms is so very critical to our ongoing recovery there. So we like to keep this agenda fairly limited because we know that there's a lot of material that relates to the health plan rates in particular, and a good deal of interest in spending time and discussing those slides. So that's why we're looking at a fairly light agenda. I had prior talked about the possibility of doing a kind of a year one retrospective, but we wanted to hold on to that for a future meeting so that we could make sure that we're giving sufficient time to these other two really important items. I will note, because Dr. Shree from CVS will be joining us at 9:30, that we may leave this kind of other business of the agenda so that we can pick up at 9:30 with his presentation and then return back to items that we may not have gotten to yet. You'll see for the, we've laid out the agendas, proposed agendas for the meetings going into the spring. And I'm really looking forward to the next meeting, providing a great deal more detail about our engagement strategy, which I've been talking about generally for quite some time. And with the arrival of Deputy Executive Director Erica Schiavelli, we've made some significant progress there. And then you'll note too at the bottom of the April agenda there that we're going to start a series of presentations and discussions at the Commission about key cost drivers. And we're going to start that discussion with some level setting around prescription drugs. I anticipate that discussion will probably take place over the course of a few meetings. And we will be focusing on prescription drugs. We will also be focusing on the provider prices, healthcare provider prices, which, as we've talked about many times, continues to be a key driver. So what we want to do is to kind of create some modules of kind of some deep dives into our various cost drivers. And then you'll see, of course, in April, we start our annual enrollment. So we are very busy preparing for that. And in the May meeting, we'll be touching on our behavioral health strategy, which we're spending a lot of time on, and circling back on our diversity, equity, and inclusion agenda, which we talked about at our last meeting. And then we'll round out the fiscal year with a number of other items that you see here. So it's a busy time for us, but we look forward to a number of fruitful discussions today and then the months to come. Next slide. So here, per our new process, I will just touch on a few items very briefly that we provided detail in writing to the Commission last week. I will say in the communication space, we are very busy preparing materials and sending out mailings around a number of different topics, most notably continuing to promote the resources that are available to all of our members and subscribers through the Mass for You Employee Assistance Program and preparations for annual enrollment. So we're really kind of ramping up some communications activities as we head into this busy season for our members. On the legislation side, I'll simply note that we have some new leadership with chairs and co-chairs of important committees in the legislature having been named. On the committee for the Joint Committee for Healthcare Financing, Senator Cindy Friedman will continue as the Senate co-chair. We have a new House co-chair, Representative John Lawn. We've already been in touch with his staff and look forward to working with both of those chairs. I will also note that the Joint Committee on Mental Health, Substance Use, and Recovery will be led by Representative Adrian Madaro and Senator Brendan Creighton. So I'm happy to say the North Shore of Massachusetts well represented there. And I think I'll just close with just a brief note about the COVID-19 data report. Because we have this meeting early in the month, we don't have updated COVID-19 claims, but we did provide a brief snapshot of the administration of the COVID vaccine to our membership, broken down by our different carriers. I will note for that, the one caveat I would offer for that table is that we anticipate that there's going to be a significant lag time for claims for the cost of administration of the vaccine, particularly knowing that for the mass vaccination sites that are being coordinated through the state, those claims will have a different process through the state, through Mass Health, before they arrive at our plans. So it's an imperfect picture, but it's the picture that we have from the data, so we wanted to share that. With that, I will pause for any questions, comments on the Executive Director's report.
Matt, Toby Choate. On your report, you briefly touch on the office move. Is there anything more you can share with us on, one, a target date, and what are going to be the major changes, just the major ones, or is it premature?
I could say a few things about that, Toby, although I'm anticipating that we'll have much firmer plans over the next week or so even. First of all, I'd say that the notion of an office move in the environment where everybody, really our entire staff, with very few exceptions, continues to work remotely is an odd concept, right? We are preparing for the transitioning of documents that we need to bring with us from here to there. We are dealing with the disposition of all of our various furnishings and copy machines and mailing machines, and so those are all ongoing. I would say when we return to the office, when the governor gives that direction to state employees, we will be returning to that space. So I don't anticipate that in the next few months. So in terms of timing for actual staff occupying that new space, I suspect it will probably not be earliest sometime in the summer. That said, we are with the leadership of Maureen Quinn, who's been running point on this, and John Harney, working very closely with her. We are transitioning our phone systems. I would say that is probably among the most important elements of our move to get right. And it's the timing of switching over to this new system and the new set of switches in our new space that is probably the most important thing for us to get right. The piece of this that is currently in flux, but we anticipate getting nailed down imminently, is whether we decide to switch the phone systems before the end of the month or whether we wait until after the annual enrollment period. We want to make sure that we have the opportunity to pressure test and use test this new set of the new system of phones and the new devices, so that when members call us, our staff are prepared to take those calls. So the last thing I'll say there is that, and I'm repeating myself to some degree of what I've said in the past, which is we are moving to a hybrid work environment that will bring forward, we hope, the best of what we've been able to learn and do remotely. I think the core principle will be for us to have staff in our new office space only as we need them specifically to be in the office. Otherwise, the default will be for staff to continue to work from home. There will always be unique circumstances with particular staff based on the work that they do that may require in-office presence, but also, other unique circumstances at, people's home environment. It may not always work for everybody, so we want to be able to be flexible and accommodate that. I'm really excited about the new space. It's a bit smaller than the space that we have, but I feel really confident that it's going to meet our needs. So again, I want to just give a shout out to Maureen Quinn, our project manager, who's been coordinating this, working with DCAM and our other state agencies. Hope that's helpful, Toby. That's kind of where we're at.
Thank you.
Other questions or comments on the director's report? I hope this format continues to work. I think it allows us to economize time, even though I spoke a good deal anyway. We are on schedule. I think that concludes my executive director's report. If there are no further questions, I'll hand it over to Cameron McBean, our manager of health and ancillary benefits, to take up the first of our various rate-related discussions. You'll note here that this is to inform, not to vote, and that is a feature of us having, as a commission, voted to approve the procurement of new dental and vision with the same carriers, but through the new procurement. So you've actually already voted to approve the rates here, but we wanted to make sure that you have the full set of information. So with that, I'll hand it over to Cameron McBean.
Thank you, Matt. Good morning, commissioners. If we could proceed to the next slide, please. Just wanted to start with a little bit of level setting. As Matt mentioned, we did renew in previous meetings. We received approval to renew the contracts with the incumbent carriers effective July 1st of this year. So MetLife will continue as our dental carrier and Davis Vision will continue as our vision provider. Andrew asked me to mention that the contracting process is complete with both of these renewals, and if any of the commissioners wish to review the actual contracts themselves, they're welcome to reach out to Andrew and do so. As a reminder, active employees in the dental plan are members of the legislative branch and members of the executive branch, primarily management, who are not covered by collective bargaining agreements. Since MetLife was also awarded the life and LTD contracts, we are also seeing an additional 1% rate reduction on the dental plans due to that consolidation and the addition of the extra product lines. Next slide, please. So this is just a quick illustration of the decrease of the rates paid by our retiree members. As you can see, it's a 5% decrease over the current year's premiums. We wanted to lead with this because the retiree population is by far, much larger than the active membership in the dental plans. Next slide. Okay, and then for the actives, there's a little bit of variation depending on whether you are in which plan you're in or whether you have individual or family coverage. But again, everyone will be seeing a reduction in their premiums. Next slide. This is just a quick illustration showing the difference in the Davis vision rates. Because these are a combined offering, we'll show you towards the end of this section of the presentation what those combined rates will actually look like. But because the vision plan is self-insured, we also wanted to take this opportunity to illustrate those savings. Because these premiums are by nature minimal, the reductions is also minimal. Next slide. So these are what the combined rates are going to look like. You can see it's just a simple matter of adding the dental and the vision. And if we go to the next slide, we'll see what the actual rates are, because members only pay 15% of the total cost of the premium. I believe this would probably be a good time to stop and see if any of the commissioners have any questions.
Cameron,
Not
I don't
seeing-
see any hands up. Good news about the premium reductions. So
Yeah.
maybe we're all speechless.
It looks like Bobby may have a comment.
Yes, Cameron, I just wanted to ask you, usually the coverage also extends to confidential employees, and they're in the executive branch anyway, and there are about 200 of them. And so I was curious whether they're included in the group that are covered by GIC dental and optical, because they're not covered under collective bargaining agreements.
I'm not, I have to be honest, I'm not sure exactly what you mean by confidential employees. There has been no change to our eligibility requirements, though, with regards to these plans. So if they were previously covered in the current year or prior years, they would be covered under this new contract.
Okay.
Does that answer your question?
Well, sort of.
Bobby,
yes.
if I
Andrew.
may interject.
Yeah, sure.
Yeah, they are covered.
Okay.
As you know, the defined group comes actually in the line item in the budget, and there's been no change. They continue to be covered.
Okay, great. Thank you.
Thank you, Andrew. All right.
Wait, Cameron, Commissioner Durant has his hand up.
Sure. Commissioner, you may go ahead.
Quick question. So I work in development services in Denver, and they used to use Delta Dental when they go to a dentist and they don't accept the dental. I'm not sure that's the question they asked me to ask today, if GIC don't use Delta no more.
It's my understanding that GIC used Delta at one point in the past, but for the last couple of contracting cycles, we have kept our dental coverage with MetLife.
Okay. Thank you.
Yeah.
Thank you.
Bobby, do you have another question?
Yes. I just wanted to respond to Commissioner Garand just by saying that if they are, since he's works at DDS, any of his co-workers who are covered by collective bargaining agreements, the dental that's offered by the union is through Delta Dental.
Thank you.
Great, thank you both. All right, Cameron, I don't see anybody else's hand up, so you may proceed. Thank you.
Okay, I believe it's time to hand things over to Jim then.
All right. Hi, Jim.
Good morning, everyone. Good to see you all. I'd like to talk to you about the subsidies for the elderly government retirees. As some of you who were here in prior years know, every year we ask that the commission authorize the subsidization of these rates for this group of employees who predate the GIC. There's some background information on the slides that I won't go through in detail, But basically, these funds are funds that were contributed by them to their fully insured program. And now we'd like to return it to them by subsidizing their rates. The goal of this subsidy is to leave rates pretty much where they are every year, which for most folks is about $1 a month. At this point, we are proposing that we use approximately $5,000 of the $60,000 balance to subsidize these rates. And the combined effect of the subsidies will be a modest decrease compared to the rates of last year. With that very basic summary, I'm happy to take any questions on this item.
See any questions? This is something that we do every year.
Correct. Yes, every year. Going back quite a while. Right? These folks were state employees before the GIC came into existence in its current form.
And can you give us an idea of how many constituents are covered by?
Sure,
this?
great question. Sorry, I didn't mean to miss that. But there are 10 employees in this category right now. 10
okay.
Thank you for that question.
Hence the low number.
Correct. Correct.
So I think at this point, I do need a motion to approve this. I don't see any other.
Seconded.
So great. Yep. So all in favor of the motion to approve that the commission spends from the elderly government retirees premium and CIC reserves to reduce the fiscal year 22 premiums. So
We need a roll call on this.
yeah, I know. I'm coming, Andrew, with that. So Chair Sullivan, yay. I'm turning it over to you, Andrew, for the roll call.
Thank you, Madam Chair. Commissioner Kaplan,
Yay.
Designee Roder,
Yay.
Designee Butler,
Yay.
Commissioner Shabbat. I'll come back because I think she needs to do this by text. Commissioner Chapdelaine.
Aye.
I had a nay from Commissioner Shabbat. Commissioner Choate,
Yay.
Commissioner Clenard,
Yay.
Commissioner Davis,
Yay.
Commissioner Guerin,
Yay.
Commissioner Edmonds,
Yay.
Commissioner Gentile,
Yay.
Commissioner McEnany,
Yay.
Commissioner Jennings,
Yay.
Commissioner Murphy Rodriguez,
Yay.
Commissioner Sinenko,
Yay.
and Commissioner Sullivan.
Yay.
I just want to confirm Commissioner Chabot's vote. Commissioner Chabot voted nay. I'm not sure. She confirms it. I thought that was mistyped. So it passes unanimously.
Okay, great. Thank you, Andrew.
Thank you all.
Thank you, Jim. So is Jim still, who's up?
Madam
next?
Chair, I'll tee this one up. This will be the meat of today's discussion. We will have Vince Kane, Senior Director from Willis Towers Watson, give a presentation that will provide a good deal of kind of background and context to the process that we've undertaken, the steps that they've taken working with our staff to develop these rates. So it's a good, full, complete presentation about the process and how we've got here. And then there'll be some kind of detailed different looks at the rate increases and the subsequent rates and the distribution among the plans and who's most affected and who's least affected. So we've done a good deal of work here to make sure that you have as complete a picture as we can possibly paint for you. I do want to thank the team at Willis Towers Watson for their really excellent work as part of this process. It's been my first time going through it at the staff level, and I could tell you that they provide really excellent support for us as part of this process. So with that, I'll hand it over to Vince to go through the presentation.
Thank you, Matt, and good morning, commissioners. Next slide, please. So today we're going to walk through what is the usual process for developing the full cost premiums and recap some of the decisions we made around plan design changes for FY22, and then move on to the rates themselves for both the non-Medicare and the Medicare populations for a vote at the end of the presentation. Next slide. So I think I just sort of spoke to why we're here today, but you know, the health insurance full cost premiums are developed annually each year. It's a process that involves the actuarial team at Willis Towers Watson, the folks at the Group Insurance Commission, as well as a multitude of folks at the health plans and the pharmacy benefit managers. And what we're attempting to do is forecast what the anticipated membership will be for each of the plan offerings for the next year, as well as the total expected claims. So that's medical and pharmacy claims, as well as the administrative expenses that are paid to the health plans to do their work. So the non-Medicare products are for the active employees of the state and also those retirees who are not Medicare approved, as well as the Medicare products for the retirees, which are Medicare sup plans and a Medicare Advantage plan. There were no changes to any of the carriers offering the plan options for next year. It's the same set of carriers and plans that are in place currently for FY21. And there were no plan design changes on the Medicare side. There was one benefit enhancement on the non-Medicare side to cover 3 behavioral health telehealth visits in full with no cost sharing during the next fiscal year. So the process laid out here, which is a bit hard to read, but color-coded, spans about 6 or 7 months in a typical year. The purple boxes represent work that the Willis Towers Watson actuarial team does. The yellow boxes represent work related to potential plan design changes. The blue boxes are, basically interactions between the WTW team and the health plans and PBMs to collect experience data and refine assumptions. And the most important boxes are the commission meeting boxes in green. So there are several meetings where we, sort of shepherd the rates to their final vote today, beginning in December with a preliminary budget update and then working through plan design changes and a final vote on the premiums themselves. The public meetings, of course, happen in January, and that's the gray box there. So backing up to September, we collect claims and enrollment for the previous fiscal year with sufficient claims run out to get a mature year and a credible experience base. We develop initial assumptions working with the health plans and PBMs to establish trend. So that's inflation. It's the unit cost, utilization, and mix of service component that helps us move the prior experience to the forecasted period, which is the next fiscal year. We refine rebates and expected Part D EGWP reimbursements from the federal government, which are an offset to the full cost premiums. And after we get a sense of what the status quo, we call it, increase is, then we consider potential plan design changes depending on what that increase is looking at, as well as strategic benefit changes, which could be enhancements, as is the case for FY22. We update and refine the data and circle back to get a fresh look at assumptions, which was especially important given the last year and the impact of COVID. And then we finalize potential estimates of the various plan design changes that are being proposed for discussion with the commissioners in January. Now, it's not until we do the final vote on the plan design changes that we can establish the final full cost premiums. And so the work that we're presenting to you today was very, very much contingent on the vote that takes place in the prior commission meeting in February. Any questions on the process before I move on? Okay, next slide. So premiums are the amount of money that is meant to cover the pharmacy medical claims, as well as the insurance company fixed retention items, for example, the administrative fees that are paid to them to, curate their networks and process and pay the claims. Premiums do not include out-of-pocket spend from the members. So deductibles and copays are not part of the full cost premium. Those full cost premiums are then split so that the members pay a portion of the premium, as illustrated on the next slide. So, premium sharing is specified by law or contractually. Here we see, splits that are basically dependent on date of hire and your employer, whether it be a state or municipality. It could be 90-10 all the way down to 75-25. So again, that would be the amount that the employer retiree pays, that the 10% going down to 25%, depending on those factors. Next slide. So one thing we wanted to clarify in the process is that virtually all of the benefit options available to GIC members and retirees are self-funded. In that case, the Commonwealth of Massachusetts is taking on the risk. So these are not fully insured and negotiated with the health plans, except for one instance I'll describe in a moment. These are rates that are built on the actual claims experience for GIC members and retirees and projected forward with reasonable assumptions, particularly around trend. So if the total eligible claims incurred by the members for the next year exceeds the premiums that were set, the state is on the hook for that, which could mean requesting additional funds. The health insurance carriers take no risk in the self-insured model. They are just processing the claims and curating the network. So this helps to keep premiums lower because in a self-insured funding mechanism, you're not paying the additional risk and profit charges that could be built into the retention of a fully insured premium. Now, the only exception is for the Tufts Medicare Advantage plan. The medical portion is fully insured, and that means that effectively Tufts is on the hook if the claims experience is higher than expected, and the pharmacy portion of that rate is self-funded. Next slide. So, there's a lot driving premium increases from year to year. The primary thing that we look at is trend, and there are components of trend, the largest of which is the unit cost, and that's driven by higher negotiated unit prices from the hospitals and physicians. In addition, pharmaceutical companies have higher prices for brand name and high cost specialty drugs. Mix is another component in utilization. Utilization has been dampened, particularly through the pandemic. Mix means, you've got more intense services or higher cost technologies being deployed and reimbursed by the state. So, CHIA reports in an annual report each year. I have not yet seen the 2020 report, but expect it'll be coming out soon. And they comment on the total spend for the state of Massachusetts and break that down into public payers like Mass Health and Medicare, as well as private, commercially insured and self-funded payers. The rates that we're about to look at are not inconsistent with increases that we've also seen approved by the Division of Insurance, particularly for the small group and individual merged market. So some of the factors driving GIC's increases are, as a result of inflation, you're paying more for the same services that were provided in previous years, and the unit cost and mixed component has been in excess of the utilization. There's also been an increase in high cost claimants from the fiscal year ending in 19 to FY20. FY20 is actually really the 12-month period going through February 2020, which was before the pandemic, and that was the base for the experience that we used to project the claims. Next slide. So this is a histogram, and on the x-axis along the bottom is the anticipated percent increase to a member's premium if they were to stay in the plan that they're in for FY21. The height of the bar are the number of subscribers, in that bucket that would experience that premium increase if they were to stay in that plan. The overall average increase across all the plans for both non-Medicare and Medicare is 5.2%. And this is in line with last year's increase for FY21 over FY20, which was 5.1%. And we observe that this is also in the low end of market trends, which are in the neighborhood of 5 to 7%. And per my comment a moment ago, the average sort of Q1 21 approved merge market insured increase was 7.9%. So looking at the left side of this histogram, approximately 2/3 of the subscriber enrollees are expected to have a rate change of 5% or less. Toward the right of the histogram, where the bars are not as high, you've got higher increases, and on the far right, 3.1% of the population could have increases as high as 12%. But of course, they have the option to select a different plan. Next slide.
Can I just ask a question before you go on? It's just a clarifying question about that slide.
Yep.
Sorry. I'm just curious, is that 5.2% a straight average across the plans, or is it a weighted average for the members?
Yes, good question. It is a weighted average increase. So it looks at the snapshot enrollment in each of the plans and the premium spend for 21, then compares that to the premium spend for 22 for the same population. So it is effectively a weighted average increase across all plans and members. A straight average would be if you just looked at the chart of percent increases and came up with a simple average, and it's not that.
Thank you.
To recap the decision that was made on February 11th regarding approved plan design changes, we were already at about a 5.1% anticipated increase for FY22 before voting in the waiver of the behavioral health copays for 3 visits for telehealth. That was pretty immaterial as far as an increased cost to the plan. It was about 0.05%, and that's how we end up with the 5.2% for non-Medicare and Medicare combined. Next slide. So here's the, I'll slow down here so we can take a look at the rates, but what we have here is all of the non-Medicare full cost premiums. It's laid out so that we're first showing the regional health plan options for Health New England and Always, followed by the narrow or limited network products, 4 of them shown here, followed by the broad-based products, which have more robust networks, and finally the national indemnity plan administered by Unicare, the Unicare Basic Plan. So generally, your premium rates or full cost premiums in dollar amount are getting higher as you go down the page. So the regional and narrow plans are the least expensive, and then the broad and the national plans are the most expensive. The overall average, again, the weighted average increase for the non-Medicare plans is 5.8%. The lowest premium increase on a percentage basis is experienced by Fallon Direct. It's about 3.1%, and the highest is with Always. Unicare Choice still remains the lowest cost product, followed by Health New England. And we will not be voting on these rates at this time, and we'll move on and recap the Medicare rates and then do a final vote, I believe. But I will stay here for a moment for folks to scrutinize the slide and either ask questions now or we could wait until we complete the Medicare section.
Hey, Bobby has a question, Vince.
Yep.
Right. So I'm wondering if you could provide some explanation regarding regarding Always, because that's a huge increase and well above any of the others.
Mm-hmm. So each of the plans is priced based on the claims experience of the GIC members who are in that plan. So the always increase reflects the emerging claims experience for the plan, as well as the trend assumptions that were proposed and reviewed by Always, proposed and reviewed by Willis Towers Watson. So, when you combine the emerging experience for the plan as well as the trend assumptions, that ends up putting them at a higher increase relative to some of the other plans. This is not inconsistent with recent news we've seen regarding Always for their fully insured block of business, and approved increases that are in the double digits going into Q1 and Q2 of 2021. I believe that we're actually in the neighborhood of what those insured increases are, but for different reasons, it's somewhat coincidental.
Yeah, and I'll just say a couple of things too, Bobby. Commissioner Kaplan, forgive me. So the history of Always is, of course, that it was a neighborhood health plan, which was a Medicaid plan, which was built on a provider network that largely utilized Medicaid rates. So the network that was inherited or purchased by Partners Healthcare, now Mass General Brigham, had that lower rate structure, and they've been, as they've exited that market, seen the expected impact on their negotiated provider rates. I think that's part of the reason that, as Vince said, we're seeing very similar trends for Always in the rest of the commercial marketplace. I may want to see if Designee Butler has anything that she'd like to add there. I will say, though, that as you'll see in the next slide, they Always Health Partners does continue to be sort of middle of the pack on overall effective premium. There's one other thing I wanted to say about this, and I've forgotten what it was. If it comes back to me, I'll express it.
Yes, hi, Madam Chair, this is Designee Butler. And I would like to say that Always went through the hearing process at the Division of Insurance regarding its rates, and that were finalized were very similar. I believe it was 11.5, perhaps in that neighborhood. So there is other justification that seems to correlate with the justification that the GIC has found for higher rates here. And I believe that Mr. Vino's correct in that the rates still seem to be in the mid increase. And that's true for the fully insured market, I believe, as well.
One might also conclude, I mean, their membership is relatively modest here compared to some of the other higher membership plans. So one could say that there's, just an element of normal volatility. I guess I'd ask Vince his actuarial viewpoint on that. Although I will say that their increase this year is fairly consistent. In fact, very close to their increase from last year. So if it were the law of small numbers, then it's working against them consistently.
Commissioner Jennings?
Thanks. I had the same question last year. Do we have a sense of how many contracts are still being paid on the Medicaid fee schedule? And when is this roll off going to be complete?
I don't have insight into that. I don't know if Matt or from the DUI has insight into that.
This is Designee Butler again. All I can say is that typically contracts for larger facilities are negotiated on around a 3-year plan, sometimes slightly longer, but I think 3 years is typical. and Always has been in the market now. So they're probably starting to move over to other contracts. However, that being said, all rates depend on the risk profile, and so depending on what kind of risk is assumed by Always for the membership that it has, whether it be in the fully insured market or through the GIC, that will impact the rates going forward and the kinds of facilities that the members use through that insurance company.
My sense is that we are coming to the end of that transition, and but we will take that back as something to dig into a little bit more directly with the folks at Always.
All right. And then Anna, go ahead. You have a question.
Yeah, I would be curious if, along with the fee schedule changing from Medicaid to the commercial rates, the extent to which the providers that are being used, like the changes in the providers that the members in that plan are using, might also be related to the cost increases. And that could be something that if you're going to go back and ask them about the contracts, you could ask them also about sort of member utilization across providers in the state and the extent to which people are using higher cost providers today relative to prior years. That would be, yeah.
Yeah, that's a good point. And when we work with the plans to establish their trend projections and to break out that trend into the unit cost component, our expectation is that they are looking at the provider mix and hospital mix for the utilizing members and running that up against their multi-year contracts to forecast what they believe that unit cost trend component is. But certainly we could get more refined information on that.
Thank you, Commissioner Seneko. That's actually, this is an area where we are really hopeful with your guidance, among others, that a new kind of more robust approach to the use of our claims data warehouse to understand with more texture, underlying dynamics and trends that we can more fully understand this with our own data.
Yeah, I think that's right. And I mean, that can also help inform benefit design in the future.
If there are no more questions on this slide, we can move to the next.
Yeah. Oh, Bobby, is that your hand up?
Yes,
with the new question?
Yes, it is, Madam Chair. I just wanted to just comment that I appreciate Commissioner Seneko asking her question. I think it's important to drill down a little bit and to receive more information on the increase with Always. So thank you very much.
And let's move on, Vince, if we
Thank
can.
you. Yep. So this slide is meant to compare the current FY21 rates in purple to the proposed FY22 rates in gold. It ranks them in increasing costs. So you've got your regional and limited or narrow network plan offerings on the left side of the chart, and then the more expensive broad-based and indemnity options on the right. This is for individual monthly premiums. On the next slide is the family monthly premiums, the same chart with the comparison of the 2 years. So, to the extent a larger percentage increase is applying for a plan that you were enrolled in, there's an opportunity in the open enrollment cycle to potentially consider a plan of comparable value and lower cost premium. Next slide. This is meant to represent monthly contributions for 4 different cost sharing percentages, 10, 15, 20, and 25% for each of the non-Medicare plan options should the rates be voted in. And this is meant to represent just the medical and pharmacy portion, not any contributions related to life insurance or additional administrative fees. Next slide. Now moving on to the Medicare plan options. Those are outlined such that we have one Medicare Advantage plan, and that's the one with the medical portion of it is an insured premium rate. And that's with Tufts, the Tufts Medicare Preferred Plan. And then the Medicare Sup plan options. These are all generally in the same neighborhood from a monthly premium perspective. And similar to last year, we're proposing an increase that is generally equivalent across the Medicare plan options and favorably emerging in the 2.1 to 2.3% range. The average across all of these is 2.3%. And the Tufts Medicare Complement Plan remains the lowest cost option, followed by the Unicare OME plan. So again, there's very little differential. Medicare sub products are similar as far as their value propositions and premiums. And the majority of the members, you can see 75,000 are in the Unicare OME with CIC.
Well, one of the things just to note here too is, and commissioners will note the difference between the collective increases or the average increases here compared to those that are happening on the active side of things. And many of you will be aware, but that the underlying fee schedules here are determined just very differently, right? That the Medicare trend is driven, at least on the price side, by adjustments by the federal government to Medicare, and therefore are a good deal more modest. Whereas on the active side, we are relying on the private marketplace and the negotiations between private parties in a system where we know we have some dysfunction and some disconnected leverage or asymmetry in some of those negotiations. So it further highlights, I think, the differences between retirees and actives here highlights the ongoing challenge of underlying provider price. Didn't want to miss the opportunity to note that.
Great, Matt.
If there are no questions on this slide,
Yeah.
we can move on.
Keep going.
Again, if those rates on the previous slide are voted in, this is what contributions would look like, ranging from a 10% to 25% premium share for just the medical and pharmacy portion of the benefit. Next slide.
So what I might suggest here, Madam Chair, is we've got Dr. Shree just about ready to go. I certainly don't want to miss the opportunity for commissioners to ask more questions or have some more discussion about this. I don't want to sort of rush the vote. So what I might suggest here is that we hold the motion, listen to the presentation, and then come back to see if we want to have more discussion before we proceed with a vote. That would be my suggestion, unless there's objection.
I don't see any objection from the commissioners, so let's welcome Dr. Shree, and we'll look forward to hearing how we can all be vaccinated very soon.
Thank you, commissioners. It's a pleasure to be here. And so I have, I think, approximately 20 or so slides here where we can move forward to slides. Yeah, right here. So, I have a few slides on vaccine update to really look through what the current science is around the J&J vaccine, as well as slight comparison of the various vaccines, and then move into an overall flow in terms of how vaccines are distributed in the country, and then what's the progress been like so far, specifically what we've done with skilled nursing facilities and long-term care facilities in Massachusetts, and what does the retail pharmacy program look like. So there's a lot of content here. I'm happy to spend more time on the vaccine science as well. There's a lot of data around variants, as well as the impact of vaccines on these variants, which I did not include in here, as well as what the future pipeline looks like, which I did not include in here. So I will continue to monitor the chat, and so please do chime in at any time, because we can take this off script if a topic comes of interest. Does that sound okay to everyone?
Okay.
Yep.
I think so.
Okay, so let's move forward. So Johnson & Johnson recently got authorized, and I wanted to walk through some of the headline as well as subtle secondary information around Johnson & Johnson. So as a reminder, we've had 2 authorized vaccines that have been on an mRNA platform, and now we have a new platform, new authorization with Johnson & Johnson on an adenovirus platform. I won't go into the details about what the various differences are beyond the fact that with this adenovirus platform, it's easier cold chain shipping and storage requirements. And so Johnson & Johnson demonstrated a 66% effectiveness in their overall efficacy. And that was after 1 dose. Now, these are very large studies that are being conducted. The FDA has an expectation that you have 30,000 individuals in your trials to be considered for authorization plus 2 months of safety data. Those are really important numbers. And as we think about what's next in the pipeline, Novavax just hit the 30,000 and will have 2 months of data by April. So you should see a 4th authorization in April, which will continue to expand our vaccine availability in this country. But coming back to J&J, what you see in this 43,000 individual study, and the reason that they went higher on the participants is that it allows you to earlier look at interim analysis on the efficacy of these trials. They had their trial conducted in 3 countries, US, Latin America, and South Africa. That's really important as we think about the efficacy because there are variants, and I don't have the longer material around the reason that we're interested in variants, but the United States has generally the wild type reference variant, whereas Latin America has growing P1 variant and South Africa has their own variant. Each one of these might have difference in vaccine efficacy, which would impact the overall efficacy rate. And that's exactly what you see. If you kind of go down to the lower part of the right-hand column, you see the vaccine efficacy by region, 72% in the US, whereas I reminded, we see the wild type strain, and then where you see these variants, you see lowered vaccine efficacy. And so there's some subtleties around these numbers that we won't go through, but the basic premise here is that the vaccine efficacy appears to be impacted by variants, which then led to a lower efficacy rate. And so but the other key headline, I would say secondary headline, and part of me would hope that we actually flip the narrative and make it the primary headline, is that anyone who got the Johnson & Johnson vaccine, there was no reported cases of hospitalizations and death 28 days after that first dose. And that is incredibly impressive. And so it's very easy for us to want to sort of compare one vaccine versus another. And as we think about our membership, our patients, and ensuring that we get those right messages across, or these comprehensive messages across, there is these headline news that you see on the left-hand side, that 66% effective, but the right-hand side about no related hospitalizations or death, regardless of the region, right, is incredibly important. Now, our desire to compare trials, to compare vaccines, it's just natural. It is really hard for us to compare different vaccines. If we move forward one slide, and I will, just to share, the reason that it's really difficult is that each of these trials have different demographics. They have different definitions. But the third piece here, probably the most important, is that these trials are conducted at different times during the pandemic and in various countries. And what we have seen is these rise of variants that have, and this is natural that these variants occur. As if we think about flu, the flu is constantly every year shifting, and we're constantly updating our vaccines for that. But as we think about Johnson & Johnson's data, they conducted the trial, and we're going to see this also with Novavax. They're conducting their trial later, where there's more variants to contend with than when Pfizer and Moderna conducted their trials. If you go on to the next page, though, just to indulge ourselves in putting everything up against each other, what you see is, yes, the headline news on vaccine efficacy, 95, 94, 66%. But those Pfizer, Moderna's trials were done before the rise of the vaccine, the variants. And then when you look across hospitalizations and death, all of these trials are incredibly impressive in the reduction in hospitalizations and death. And if you think about our desire to, first and foremost, reduce mortality in this country, there's essentially equivalence across of these vaccines. And then to reduce the stress that we have on the healthcare system from a public health perspective, these are all good. We're going to have more data in terms of will it impact transmission or asymptomatic infections? And so happy to come back as that story evolves. The data continues to suggest that across all of these factors, asymptomatic infections and transmission, it appears to really do have protection, but we can't definitively say that yet. So there, our continued measures of masking, social distancing, hand washing will continue to be important until we can really resolve that and then break community transmission. So let me just pause there before we start moving on to more practical matters and how we're moving vaccine through the country. Any questions around the science of the J&J product or any of the other products?
I don't see any, Dr. Shree. This is really helpful, and appreciate you putting it into this context so you can move on.
Okay, great. So moving on to the next page. So what we wanted to do is really talk through the vaccine rollout through CVS Pharmacy. If we move forward. So, as a reminder, there is essentially multiple paths by which vaccines are being distributed through the country. And so the federal government has purchased all of the vaccines ingredient costs and ancillary kits in the country. And there's essentially three paths by which the vaccine product is being distributed. One is directly to the federal government itself. So for example, to FQHCs or to the Indian Health Service. And so there's a small amount of distribution happening that way. There's another path of distribution, which is happening to the states, and the states are getting a proportionate to population and based on the vaccine availability at any one given day or week. And then the states can then distribute that out to their own partners. And then that can include hospitals, to physician offices, to mass vaccination sites, to pharmacies, or to other trusted vaccination partners. And then there's a third vehicle where the retail pharmacies are playing a role with direct allocation through two named programs, the Federal Pharmacy Partnership, the Federal Long-Term Care Partnership. And so in these direct allocations, the federal government has partnered with pharmacies to support either LTC, skilled nursing facilities, or to the general population. So the LTC program, the way that it was set up is that in conjunction with the Centers for Disease Control, we worked with us and Walgreens and a small number of other pharmacies, worked with the CDC to collect data from the states on which phase, and by phase, I mean skilled nursing facilities were considered first, all other facilities were considered second phase, like assisted living facilities or long-term care facilities. So states would determine when each of these would be activated, and then CVS would then contact the facilities based on an intake form, schedule 3 visits, and we would get allocations from the CDC to perform the vaccinations. If we move forward. So we have across the country have 40,000 plus facilities that have selected CVS as the primary vaccinator. We've completed now 70,000 plus clinics on site for the individuals who are in these facilities, and that's patients plus staff, and have administered over 4 million doses. We've completed first and second dose in all skilled nursing facilities in the country. And are near completing in the upcoming weeks the remainder tail of facilities. Specific to Massachusetts, the data that we post this every single day at 4 p.m. on our website. So you can look up CVS SNF vaccination data. And so you can track Massachusetts specific, and we have that across, it's the raw numbers as well as the percentages. And we've completed, over 230,000 doses in Massachusetts. So we've been really honored to be playing a role in the vaccination of our most vulnerable individuals in society to COVID-19, those who are in congregate living facilities. And if you look on the right-hand side, this will continue to be elucidated in the upcoming weeks. But there's increasingly data that's showing that the vaccination efforts really had a substantial impact that is more outsized than what we were seeing as a country with the decline overall. And you can see the lines diverge about 2 to 3 weeks after on the right-hand side in deaths as well as new cases. So as a reminder, from a science perspective, we start to see impact about 2 to 3 weeks on vaccine efficacy as your immune system trains itself to recognize and manage COVID-19 if you're exposed to it after vaccination. And even though we saw this increase in case rates in the rest of the country, skilled nursing facilities continue to decline and declined at a faster rate than what we're seeing in the general population. So, this is to definitively say that vaccines played a role is, I can't come out and say that, but the evidence increasingly is showing that it has, and the number of deaths averted will be substantial when we kind of look back at this. So it's really been an honor to be part of this program and to help support the Commonwealth in vaccinating its individuals in congregate living facilities. Any questions on this program? Okay, so moving forward. So as I had mentioned, that was one named pharmacy program. And then we have another pharmacy program, which is the Federal Pharmacy Partnership, the FPP. And so the Federal Pharmacy Partnership provides an allocation to pharmacies through direct allocation. And then and I will talk about and then we are able to, once we get an allocation, turn on stores that allow us to vaccinate the general population. We do this specific to the criteria of the state. I'll walk through how we do that. You can see Massachusetts numbers, 47 that are active in the federal program. We also have stores that are active in the state program, so we get allocation directly from the state. So you can see how Massachusetts is in a hashed federal state partnership, whereas in some states it's only by state and others only by federal. We have the capability of opening up all 10,000 of our stores and doing 20 to 25 million doses per month. So as vaccine supplies expand, we expect to be able to open, and we have the capability of opening all 10,000 stores. We continue to advocate and look for expanded access. And if you think about the COVID-19 testing efforts, right? We started out with these large 10 sites as we were trying to really get our hands around testing. But we don't test in large 10 sites now. It's distributed. It tends to be much more hyper-localized. And that, quite frankly, is where vaccinations will happen as well as we start to move this more locally into communities in a more consumer patient-friendly path. And then we also know that a substantial portion of the population is undoctored. And so as an adjuvant to the hospitals and physicians, having a consumer-friendly path will help support the broad vaccination of the Commonwealth's population. So we look forward to continuing to expand the number of stores. So before I move on, any questions about this? We'll talk more about what the specific program looks like. I think I have 10 minutes, right,
Yes,
Commissioner?
no,
Yeah.
you do.
Okay.
And there's no questions, so keep moving.
So in terms of the curriculum in the in-store experience, we have we have a standard training program that's accredited by the Council for Pharmacy Education. We have we have all the standard operating procedures in place to manage anaphylaxis. We have CPR certification. For our individuals who have been long-standing providing vaccination services, as you know, we have been providing CDC preventative vaccinations for years in our retail pharmacy locations. We provide annual injection technique refreshers as well. So in addition to this sort of curriculum for clinical operating procedures, move on to the next page. We also have strict guidance in accordance with the CDC about the protocols that would need to be used for immunizations as well as after immunizations in terms of screening, protection, and sanitization of the sites. If we move forward to the next page, I wanted to walk through sort of what that front end experience looks like. So given that there's rapidly evolving guidance, what we have done is on the cvs.com website, every week we get our allocations from the states, and then we update our screener accordingly. If we move forward to the next page, then we have a digital first, but not a digital only.
Can I interrupt for a moment, Madam Chair, if I may? Just in the interest of time, Dr. Shree, if there are slides that are focused on hesitancy here too, yeah. I want to make sure that we don't.
Yeah, let's go forward 3 slides. Yes, Commissioner, let me move forward. Okay, so here we are in terms of hesitancy. So if we move on to the next page. So I think we know this very well, the disproportionate impact on mortality, and this is one of many unfortunate measures. And so if we look at hesitancy as well, so this is impact in terms of disproportionate impact on Black and Latinos compared to white. If you move to the next page. So we have been publishing white papers through the pandemic. And these white papers are based on national demographic surveys that we've done that mirror the demographics of the United States. So in November, as well as in January. And the headlines here is that there's significant differences by race and ethnicity, with more hesitancy among minorities than we see among non-minorities. And then safety and efficacy are top concerns across all populations. For those who want to get a vaccine, desire for life to return to normal and important. So as we think about messaging to patients and members, safety and efficacy to overcome hesitancy, the desire for life to return to normal is important as well. Move forward. So this is the data that we have in terms of our 2 surveys from baseline in January. And you can see that there is a substantial movable middle. So the top is those who want, the bottom is no, and in the middle is I'm not sure. It's either I'm not sure or I'm just going to wait. And what we saw is that over time, there's more who are in the top, but there's also more in the bottom and less in the movable middle. We started to see some stabilization, but we haven't seen a decline in the hesitancy. Our next large study is about to launch. And so we'll bring back additional data and we'll be publishing that. Now, if we move forward, and you can see that the hesitancy is greater in the Black and Hispanic community than in the white community. So this is a particular concern. Move forward. So as we think about the specific points of how we're going to address hesitancy, it's using our our retail locations, expanding beyond our retail locations, making it easier to access either retail locations or non-retail locations, and an education campaign. So let me walk through those things. If we move forward. So when we look at our CVS pharmacies, as we map them up against the CDC Social Vulnerability Index, we see an equal split between very high and low. When we get allocations, we over-index for very high, actually 0.8 or higher in terms of social vulnerability and turn on stores in high vulnerability communities. And we also have a highly diverse workforce. We believe that the people who are vaccinating need to be from the community, look like people from the community, and understand the issues of the community. And so we see our pharmacists are 40% non-white, our pharmacy technicians are 52% non-white. We have specific store formats, Navarro and Imas, that are designed to have deep relationships in Hispanic communities, as well as continued investment in increasing those percentages on the top right. So and that social vulnerability index, we look at it also at the zip code level as opposed to the county level, so more granular than how the CDC has constructed it. And if you move forward, we're establishing offsite clinics. We're looking and partnering up with community-based organizations. We just announced a partnership with the YMCA, which will help us to provide these offsite clinics for those individuals who are not interested in coming to a retail location or to expand the retail locations, as well as mobile vaccination clinics. We have identified 20 potential sites and will continue to expand over time.
Dr. Shree, we have a question from one of the commissioners, Eileen McInerney.
Yeah. Thank you. I just had a quick question about the hesitancy of people of color to take the vaccine. Is that something that is more prevalent in the United States, or is that kind of a global issue, do you know?
So I can't, everyone asks these questions differently. There are, for example, in France, there's significant hesitancy as well. There's been a lot of social media concerns there. So, and I've seen media reports on that, but what I haven't seen is sort of a head-to-head against it. Again, let me talk a little bit more. I didn't include these slides on hesitancy. What we see is that safety is a major concern across all race and ethnicities. So talking about the importance of we didn't cut corners is really important. The other piece here is that when we asked who are the people that can help you overcome these concerns around safety, invariably clinicians came to the top, physicians, pharmacists, nurses. And so amplifying messages of clinicians is really important. Who was not on that top list was politicians, celebrities or athletes. They were really very low, and that was consistent across race and ethnicity. So I just wanted to share that as well. Commissioner Edmonds, I see your hand is up.
And could I just ask one follow-up?
Yeah.
And that's, was there variation in the hesitancy among different regions in the United States? Do you know?
Yes. So there is more hesitancy in the Midwest and the South. We saw more hesitancy among Republicans. We saw more hesitancy among women. We saw more hesitancy among younger populations. So, and when we sort of look at uptake in the retail locations as well, we're seeing a little bit lower among white Republicans over the last week than we see among other communities right now.
Thank you.
I just wanted to interject that I would hope that CVS education campaign is grounded with an understanding of the history of our country. And one answer that I think you certainly will see from anyone who's lived experience as a Black person in this country will reveal that the hesitancy that some may have about having a vaccination can be traced to our, frankly, sorry history, as we have treated Black people in an inferior status from slavery till now.
Yeah.
More specifically, the Tuskegee study alone should illustrate that Black people have been taken advantage of at times when they were treated for syphilis. There were at least over 100 deaths from people who were used as guinea pigs. And that's part of our sorry history. So until we understand the history, where we were and where we are now, it will be hard for us to figure out where we're going.
Yep.
So I would assume that a CVS understands that trying to educate, quote, the Black community,
Yeah.
CVS has to understand the history of this country.
Commissioner, totally agree. There's many historic reasons, and that is one of the many issues that we need to contend with, both CVS, GIC, public health authorities, right, as we try to help support. I will say that it's really important for us not to forget also that safety and efficacy are primary concerns in our research data, specifically near term around the vaccine. So we have to also make sure that we really fully address that corners weren't cut. This is a safe and efficacious vaccine, and that we're seeing, incredible results in preventing deaths in early data as well. So I want to recognize and also your comments, and also talk about the fact that the major issue that came up in the survey data, though, was safety and efficacy near term about the vaccine.
All right, great. Well, we just have a few more minutes here. I think that was a great comment, Jane. Thank you for bravely bringing that up. Dr. Shree, you've got about 2 more minutes. You've given some great data. I'm hearing from you that it's critical for anybody who's listening, who's a practitioner or a clinician, to reinforce the confidence you have in the vaccine, regardless of which brand it is.
That's really key. It's amplifying the messages of clinicians, amplifying messages of safety and efficacy, increasing access in all in communities that are high vulnerable communities, where Black and Hispanic, specifically in Black and Hispanic communities, is really important. So it's sort of a supply and demand issue in thinking through this. And so as we think about the specific role of retail pharmacies, pharmacists are from the community. They're conveniently located in walking distance to most people, and pharmacists are continuously considered one of the most trusted professions within healthcare, and have deep relationships with people in the community. So we believe that pharmacies will play a critical role in addressing hesitancy.
Yeah, no, that's terrific. And I would just encourage you and your team at CVS to continue to remind all those independent pharmacists who are out in the community to really get out and advocate for this, because oftentimes, you can see them behind the bench and they don't really come out, but every opportunity they can to do that would encourage better vaccination, especially in the communities of color.
Yeah,
making those efforts.
We didn't talk about our exact operating model. There's a slide here, but all of this is done in front of the counter in the store, dedicated for COVID, with a dedicated greeter who's really talking through what does it mean to be vaccinated. So, Commissioner, we definitely agree with you.
Awesome. Well, that's terrific. Well, we appreciate your efforts. I enjoyed the data, and we can't get it out, at least from my perspective, we can't get it out fast enough to help stop mortality of this terrible virus.
Thank you.
Thank you.
Madam Chair, I just want to express our thanks, my thanks as the director, for Dr. Shree for joining us here today. I don't know if he's able to stick around for discussion. If he is, we'd love to have him stick around. I did want to leave a little bit of time for additional discussion or questions to Dr. Shree or to us as we proceed here. I do want to note that the vaccine numbers that we included in the executive director's report, I neglected to mention that that does not include our retirees who are enrolled in Medicare plans, because Medicare is covering the full cost of the vaccine and administration. So it doesn't generate a claim whenever one of those individuals gets a vaccine. So that was as Dr. Shri has noted, was a big early push through the long-term care facilities that CVS was a really important part of. I do want to note here too, just for the sake of fairness and completion, that our folks at ESI, at Express Scripts, are also deeply involved in a number of these same initiatives. So I want to thank them. I want to also thank our carriers who have really stepped up to the plate as it relates to communications to our members, to outreach to eligible members, those who are eligible for the vaccine, as well as healthcare providers. So I just want to a shout out there. The GIC website, we've been focusing a lot of energy of late to make sure that our GIC website is a helpful resource, clearinghouse for information about the vaccine from a variety of different sources from each of our plans. We've developed links into each of our plans, dedicated web resources on this, as well as resources from the CDC and the Department of Public Health. We are also leveraging our social media tools to amplify and to expand upon the messages that are also coming from public health authorities. So we are constantly looking for new opportunities to play our part here with our membership, and we'll be continuing to refine that, which will be particularly important as we head into the more general population distribution of the vaccine.
Thanks, Matt. Thanks,
I had
Dr.
a little bit
Shri.
of time here for dialogue.
I don't see any hands up. I thought the dialogue that we did have was strong. So we may be able to move on from this.
Just one last comment too, to relative to Commissioner Edmonds' comments. I mean, COVID-19 and particularly the hesitancy around the vaccine, these are one of many long-standing areas of health disparities. They have deep historical roots that are going to take some substantial efforts to build trust in certain communities. Again, we will be looking to do our part as part of that effort going forward as well.
Right. No, I think that's great. And you are very committed, Matt. I know that. So thank you. Bobby, a quick question.
Yes, I have a quick question for Dr. Shri, which is regarding, I'm very curious if the data, if you have data on the Black and Hispanic communities regarding the flu vaccine, because CVS has had a long history of providing flu vaccines. And I'm very curious whether the data for the flu vaccine is consistent with that for COVID, as far as the numbers and sort of the trust that the Black and Hispanic communities may have.
It's a really good question, and I don't have that information. You know, let me see if we can go back and look at any historic data, either from us or from published data overall. I think as, you know, Commissioner Edmonds said, you know, there's historic distrust. And so I would not be surprised if there's discrepancies around that. But, you know, the question, the other question is the reasons different or are they similar? Is it because of safety and efficacy concerns? or other issues. What we do know with the COVID-19, based on our research, is that safety and efficacy are really primary concerns, and it might be different for the flu. So I don't have answers for your question on hand.
Thank you.
May I?
Yeah, go ahead, Jane.
Well, you know, I guess for me, I don't always expect answers, but in any presentation, I think it's really important to acknowledge that one thing that should be thought about or explored is what I presented, and that is the history. And then the second thing is, all we have to do is look at existing data as it affects the Black community, whether we're talking about wealth, whether we're talking about higher education, whether we're talking about people who live in Back Bay have a mortality rate of 92, and in Roxbury they have a mortality rate of 59. Black and brown communities, you know, are disadvantaged and against hard data. So for me, logically, when I'm informed by that data, and as a Black woman whose lived experience has seen some of that harm personally up close, it doesn't surprise me that there is some hesitancy in the Black community to put their arm out for a shot. I have to tell you, I've been vaccinated myself, and I was fearful inside about doing it, feeling that I'm in a no-win situation, and I'm an educated woman. But I'm also, and I've had a lot of privilege, but I've had also the pain of that data that's real to me. It's not numbers, it's people. So anyway, for my 2 cents, I hope
I'm complete agreement. We have to recognize
that as you talk about educating us, that I would like to hear that we acknowledge that to educate us means that we have to educate us as a society and understand that this thing called racism is in the air, just like COVID. And we breathe the same air, and it's affected all of us. So I want to hear that in a presentation to at least acknowledge our history. So, thank you.
No, thank you, Jane. I do want to acknowledge Dr. Shree and the good work, though, in acknowledging where the presentation may evolve at another turn with the flu information and some of the points that Jane brought up. But at this time, if we don't have any more questions on vaccine, then I appreciate you coming, and then I think we need to get to a vote or pick up where we left off. So thank you again for coming. Thank you for all your commitment. Thank you to your pharmacists and clinician team. Let's get people vaccinated.
Thank you.
Thank you, Madam Chair. So, and thank you again, Dr. Shree, for joining us and all the good work that CVS is doing in this space. So we have about 20 minutes left to come back to the plan rates. We also have one additional step, which is to approve the municipal admin fee, which will be pretty straightforward. That is not changing. And I do want to just sort of tee up this final bit of discussion about the health plan rates with a couple of comments. One is just to reemphasize that when we presented to the commission back in the beginning of this process, we had projected an average aggregate annual increase across our plans of 5.8%. We were able, through continuing work and pressing on the assumptions of our carriers, and with new data about prescription drug rebates, to bring that down several basis points, down to 5.2%. So that is at least moving it in the right direction. That is still not a sustainable number, for sure. That is above, that's rising higher than inflation. It's rising higher than or faster than state domestic product. It's rising higher than the HPC benchmark, and certainly rising higher than wages. So I just want to make sure that you hear that from me, that we're we see this as a real challenge that we'll face going forward. It is, those numbers do compare favorably to the rest of the commercial market, as Vince noted, with increases in the commercial market of in the mid 7s. We were recently, I was recently on a webinar, I'm forgetting the source now, where a broker voice was talking about increases in the range of 7 to 15%. So we do compare favorably, which is good news. I will say that, particularly as it relates to the Always Health Partners increase, that it really highlights the importance of members to shop as part of the annual enrollment period. We have not typically seen a lot of that kind of activity in the enrollment. As a small percentage actually changes their coverage, but that's precisely the kind of activity that we want to strongly encourage our members to do. You have available to you, if you're in the Always plan today, options that are very comparable with a lower increase, and in some cases a lower premium. So that will be especially important this year. I think it too, I've said this before, but I want to reemphasize it, that the plan design changes that we modeled for consideration, but ultimately did not recommend to the commission, they don't move the needle a whole lot. So our tools in the year-to-year range of plan design changes don't typically produce significant downward pressure on premiums. They also, as we know, create friction for our membership and disruption for our membership. They often fall in the category of shifting cost off of premium and onto out-of-pockets and deductibles. So that does really point us towards the importance through the coming procurement, which is really our most effective tool to provide value and affordability for our members, to do some really creative and some big thinking.
Let's get to a vote, Matt.
Yep. Well,
a discussion,
yes.
Discussion before a vote.
Thank you.
So definitely don't want to imply that I'm not looking for discussion.
Yep.
So yeah, none of us like to see that there has to be an increase in premium. Do I have some questions on the rates, some comments? I don't see any. At this point, then, I'm looking for a motion to approve.
So moved. Davis.
Okay.
Seconded. Kleiner.
Seconded. Is there discussion? I see Bobby has her hand up.
Yes, I just wanted to comment that, of course, for the majority of our active membership, there have been no increases at all, no salary increases for the last 2 years. And as has been mentioned and Matt so succinctly stated, recognizing that, that costs for everything else have increased, and given the effects of COVID, that the increases are certainly more than they're just not affordable for many of our members. And so I just wanted to mention that this is my ongoing comment annually, and however, it's true. And in years past, the increases are not consistent at all with inflation or higher costs of living, and create quite a burden for our membership.
Thank you, Bobby. There's no doubt. Any other comments? Well, at this point, I will pass it over to our general counsel to take a roll call. Andrew, I'm a yay.
Thank you, Madam Chair. Commissioner Kaplan?
No.
Designee Roder?
Yay.
Designee Butler?
Yay.
Commissioner Shabbat? I'll move on
she's
and
texting.
report back on her vote. Commissioner Chapdelaine,
Aye.
Commissioner Choate,
Approved.
Commissioner Clenard,
Aye.
Commissioner Davis,
Yay.
Commissioner Giron,
Yeah.
Commissioner Edmond,
Yay.
Commissioner Gentile,
Yay.
Commissioner McEnany,
Yay.
Commissioner Jennings,
Yay.
Commissioner Murphy Rodriguez,
Yay.
Commissioner Sinenko,
Yay.
and Commissioner Sullivan.
Nay.
Is that a nay?
Yes.
Thank you. Commissioner Chabot has voted in affirmatively. So the vote has passed with 2 negative votes. So it's 15 affirmative, 2 opposed.
Thank you, Andrew.
Thank,
All right,
thank,
at this,
thank you, commissioners. Before we move to the next, it just occurs to me as we're saying yay, it's only an affirmative as opposed to a celebratory yay. I think we all, as Vice Chair Kaplan noted, are very mindful of the burden that that the rates present to our members, and will be continue to focus on that. So the final item on the agenda here is the Municipal Administration Fee. For this, I'll turn it over to our CFO, Jim Rust.
Hello, everyone. The last thing to vote on today is the FY22 Municipal Administration Fee. As you know, we charge a fee to the municipalities to administer the GIC program. This fee was 0.35% last year of full premium. We are recommending the fee stay at that same rate of 0.35% for FY22. Is there any questions on this item?
this is just to confirm, this is the same fee that we've been charging for significant.
Correct.
time,
Yes, at least for the last, I should have the history, at least last 3 years. Right?
And it's below what we are authorized to do.
Correct. There's an authorization from we collect. It gets a little complicated, but we collect the statutory allowed amount, which is less than what we're authorized to charge.
And the municipalities feel very good about the service we're providing at this level. Not for the CFO to answer, but for other municipalities to consider what a good deal they get with the GIC.
Yes, the feedback we've gotten has been positive in general.
Okay.
And we are seeing, just to note, I didn't mention this in the executive director's report, but we have received no inquiries from our current municipalities about an interest in reviewing their options and with an eye towards potentially leaving the GIC. We continue to see a fairly stable municipal membership. So I just wanted to note that.
It looks like both Adam and Melissa have their hands up. So please, Adam, go first, and then Melissa.
I will just quickly say, thank you, Chair Sullivan. I'll just quickly say, I both appreciate the work that the GIC does in terms of administering the program for municipalities, and I also appreciate maintaining the same level as it's been in past years at the 0.35%. So I fully support this.
Thank you.
And I will just echo Adam's sentiments. This has certainly been a difficult budget year for all of us as municipalities. Our budget as a whole only able to increase by 2.3%. But I will say that being a municipal member of the GIC has actually kept our insurance payment the same as it was 11 years ago. And so being a member here has really been a positive for my community. And seeing this 0.35% again this year really takes a lot of that burden off. So thank you.
Oh, thank you. And if there are other municipalities that either you, Melissa, or Adam want to encourage to evaluate the GIC and hear more, especially now with YouTube, we reach so many more constituents every month. I know there'd be a lot of satisfied municipalities in addition to the ones we already have. So appreciate this opportunity. All right.
So I would move approval.
Yes. Okay. So let's move to a motion.
And I would
Maybe.
second that.
And so I am going to pass it over to General Counsel for roll call with my registration of approved.
Sorry, I had to get off mute. Thank you, Commissioner. Chair. Commissioner Kaplan,
Yay.
Commissioner Roder,
Yay.
and keeping that, Commissioner Butler,
Yay.
Commissioner Chabot. And again, oh, it's come through already. She's an affirmative. Commissioner Chapdelaine,
Aye.
Commissioner Choate,
Aye.
Commissioner Clenard,
Aye.
Commissioner Davis,
Yay.
Commissioner Guerin,
Yay.
Commissioner Edmonds,
Yay.
Commissioner Gentile,
Yay.
Commissioner McEnany,
Yay.
Commissioner Jennings,
Yay.
Commissioner Rodriguez,
Yay.
Commissioner Sinenko,
Yay.
and Commissioner Sullivan.
Yay.
The vote passes unanimously.
Well, thank you. Thank you all, especially to the staff of the GIC for the good work that's been done in this short amount of time. There's always a busy time for the GIC.
Thank you, Madam Chair. I just want to echo that thanks to my staff and to our partners at Willis Towers Watson throughout this lengthy process. It's, as I said, it's been my first run through all of this, and I'm impressed with the level of thought that goes into all of what we do here at the GIC to prepare for the coming annual enrollment. I want to acknowledge the team also in operations and IT, Paul Murphy and John Harney and their team, and the communications team as well, for all of the work they're doing to make sure that the coming annual enrollment will be as smooth as we can possibly make it. So I just want to take a moment to acknowledge them.
Yep.
Thank you.
Duly noted. And Tamara, Commissioner Davis, did you have a comment or a question that I may have missed your hand up for?
Yes, it was a follow-up. I was just wondering whether or not we have an assertive plan to send the message out to the other municipalities that are not partnered with us as to the advantages of being partnered with us. In other words, are we marketing?
Yes. Yes.
Yeah,
no, I think that's an excellent question.
It's a very good question, and I would say that is an area where we intend to do a good deal of work in the months to come, now that we have this work of preparing for annual enrollment behind us. So our municipal strategy also falls under generally our, at least internally at the GIC, under our engagement and communications team. So with the arrival of Deputy Executive Director Shabelli just a few months ago, I will be working closely with her and her team and others here at the GIC to provide some more detail back to the Commission in future meetings on that. But that is, as I stated, I think through my through the interview process, that this is an area where I have some background as well as a former municipal elected official, particularly as the chair of our finance committee in the city of Salem. So I know I know how how much value we have to offer to municipalities.
So Matt, am I hearing roadshow, you and Erica? And then my last comment might be that potentially we are looking as commissioners, or I'm representing Tamara's question, for some sort of a presentation in the upcoming meetings. We'll let Erica get settled on, what the plan is to engage municipalities. Love to hear that.
That is correct. And I will note that while we have not had formal expressions of intent for additional municipalities to join the GIC, we do have some informal conversations, informal outreach from several, including at least one pretty good-sized city in Massachusetts. So there is interest out there, and I think therefore an opportunity for us to note the specific benefits. Commissioner Rodriguez noted them as well from her experience, and Commissioner Chapdelaine. So we intend to give this some thought and bring back to the commission at a future meeting.
All right, great. And Toby, I see your hand was up. And
okay, yes, thank you very much. Just as we wrap up, I want to make sure to get on the agenda for the next meeting is a discussion of the where we're at with the conjoint study and where we're going with that. And I think it's especially important given what Matt said earlier in the vote we just taken, because every time we vote for these increases, I feel powerless because we say we really don't have many levers to pull. Well, one of the levers, and I'm not sure it's a lever as much as an education, is to really get to understand what our members are looking for and be able to educate them or present them or interact with them in a way that says, maybe there are some other options you can save money that meet your needs. And hopefully the study would get at that. So I would like to get it on the future agenda, please.
Yeah, no, I think it's a great comment. And even the education around our members being able to shop and use their power to send messages to the carriers that these ongoing premium increases are not to be tolerated, and that will be powerful.
Yeah, so if I could just make a brief comment on that, Madam Chair, and thank you for the question, Commissioner Choate. We, as I noted in the calendar section of the agenda, have an update on our engagement strategy at the April meeting. Part of that will include an update on the conjoint survey. As you correctly noted, Commissioner Choate, engagement is sort of it's a two-way dialogue. It is in part to solicit data and information about the various priorities of our members for us to consider, but it's also an opportunity generally, not just the survey, but generally the engagement strategies to help them understand the challenges that we face that will ultimately lead us to the recommended solutions as part of the next procurement. So that's why we're thinking about it in the broader context of our engagement strategy with our members and other stakeholders. But I want to thank the Commission for consistently keeping the pressure on us as a staff to not lose sight of the survey. I can assure you that we are not. We are thinking about it in this broader context so that we can get the most useful information back from our members.
Thank you.
Yeah, that's terrific. All right, well, we're right at time. Any final comments, Matt, on the other business slide?
I don't think I do. Just one other item I want to note is that, and this is going back to our calendar, we are anticipating having the Health Policy Commission and Center for Health Information and Analysis, David Seltz and Ray Campbell, respectively, to be presenting to us in June. We would typically have done that in the fall, but the cost trends report was delayed due to COVID. So I do think, though, that it'll be good timing and really helpful as part of our deeper dives with you on the key cost drivers of prescription drugs and rising unit prices on the part of providers. So I look forward to the opportunity to have them to dig a little more deeply into those issues. With that, I want to thank my staff. I want to thank you, commissioners, for all of the work and guidance that you do for us.
Yeah, no, and your 1-year anniversary is coming up, so congrats on that, and thank you for your service, Matt. And so if there isn't any other comments, Bobby, I see your hand is up.
Yes, so I just wanted to congratulate Matt and GIC team once again for a wonderfully informative and incredibly interesting presentation today. All the CVS information, which is the first time we've ever had that, was great. It was fantastic, and I would like to have more of that in the future. You know, as far as vaccinations, whether it's flu or COVID or boosters or whatever, and other information that might help us, particularly as it relates to Black and Brown communities. I think that would be terrific, a terrific addition. If we could do that, it was really great. Very, very interesting. And thank you.
Always nice to get the co-chair's endorsement of a meeting. So that's great.
Oh, well, thank you for that.
You're welcome. So if there isn't any other comments, I will wish you all a happy spring, and let's go vaccination. Let's go away COVID. And let's get the nice weather to come. So at this point, I don't need a motion to adjourn. As chair, this meeting is adjourned. So thanks, everyone.